Chapter 2 is going to deal with pharmacodynamics. We start with some basic definitions. When you think about the terms agonist and antagonist, it should be very easy terms for you to define. An agonist basically is a drug that's going to stimulate its receptor, causing a response, whereas an antagonist binds to the receptor, blocks the action of an agonist. The antagonist by itself is not associated with a response. It simply blocks the action of an agonist. We're going to talk about an example in autonomic nervous system of receptors that actually don't have a physiologic agonist. The action of blocking those receptors, if there is no agonist, an antagonist is going to have no effect. There are three terms that you need to be familiar with because they might show up on a dose-response curve. You might be asked to compare affinity, potency, and efficacy of two or more drugs on a dose-response curve. Let's make sure we can do that. First, if I'm asked to compare affinities, affinity on a dose-response curve is measured by the proximity of the curve to the y-axis. In other words, the curve that is shifted closest to the y-axis represents the drug that has the greatest affinity. We have one big assumption here, and the assumption is the curves have to be parallel. In other words, the only way to compare affinities is if the slopes of the curves of these drugs you're comparing are parallel, and we'll see some examples of that. Potency on a dose-response curve is very similar to affinity. It's also the proximity of the curve to the y-axis, but in the case of potency, the curves don't have to be parallel. The slopes of those curves can be non-parallel, and you can still compare their potency. Finally, efficacy. Efficacy might be the easiest of these three terms to compare. Efficacy is the effectiveness of a drug, and that's shown by the maximum height. In order to compare efficacy for a couple of drugs, look for the curve that is the tallest. The tallest curve would be the drug with the greatest efficacy. So these are our dose-response curves, where we're going to compare affinity, potency, and efficacy. Let's take the curve on the left and compare drug A to drug B. The first term I want you to compare is affinity. In order to compare affinity, you have to look at the slopes for drug A and drug B. Notice how the slopes are parallel. Since the slopes for A and B are parallel, what that means is those two drugs work on the same receptor. If and only if the drugs work on the same receptor can you compare affinity. So the slopes have to be parallel. What do you say? You say since A is shifted closer to the y-axis, drug A has greater affinity for its receptor compared to drug B. When you think about potency, it doesn't matter if the slopes are parallel. You just simply look for the curve shifted most to the left. Curve A is closer to the y-axis. That indicates that drug A also has a greater potency than drug B. So to summarize those things, greater affinity and greater potency for drug A compared to drug B. Notice though that the curves reach the same height. Drug A and drug B both reach 100% response. That means they have equal efficacy. They are the same when it comes to their effectiveness. Now let's look at curves for X and Y. Notice how, if we start with affinity, notice how the slopes are not parallel for drug X and drug Y. Since the slopes are not parallel, you should conclude that drug X and drug Y work on different receptors. Since they work on different receptors, you cannot compare their affinities. Affinity is a term that you can only use when you're talking about a single receptor with multiple drugs. When I look at drug X and compare its potency to drug Y, the curve for X is shifted closer to the y-axis, so drug X has greater potency compared to drug Y. Notice also that drug X, the curve reaches a greater height. Drug X goes all the way to 100% response. Drug Y falls well short of 100%. So you would say that not only does drug X have greater potency, it also has greater efficacy. Now we're going to explore the concept of full and partial agonists. We use the term full agonist to describe an agonist that reaches its maximum response. If you're plotting it on a percent scale like you see in this graph, if the agonist curve reaches 100%, as we see with drug B, drug B would be a full agonist. If I told you that curve A and curve C also represent agonists, you would have to describe those as partial agonist. Partial meaning their maximum response is less than 100%. And we see that for both curve A and curve C. We're really just comparing efficacies here. So curve B has a greater efficacy compared to drug A and drug C. In case you're thinking that a partial agonist is really an ineffective drug or a drug that would be kind of useless, that's not really true. Because if you look at your dose response curve here, if you look at the responses on the lower part of this scale, let's say it's 50% or less, and that is the desired response that you want from your drug, all three of these drugs would give you that effect. Drug A, drug B, and drug C would all reach at least the 50% mark. But if I wanted a response from this particular drug or in my patient that's in the upper range of the dose response curve, up around 80, 90, or 100%, only drug B would give me that effect. This graph shows what's called the duality of partial agonists. You see, in the body, partial agonists can actually have different types of actions. By definition, a partial agonist can stimulate the receptor. It can act as an agonist, after all. This graph is here to show us what happens when a partial agonist is placed in the presence of a full agonist. Obviously, you can start to predict that the partial agonist and the full agonist can compete for the same receptors. Let's take a couple of examples and then we'll go through the graph. The first is the example of the drug Pendolol. You probably recognize Pendolol by the last four letters of its name. OLOL indicates that it's a beta blocker, and that is correct. Pendolol is a beta blocker, but it has the special property of being a partial agonist. That means if you could somehow isolate a heart and add Pendolol to that heart, Pendolol can actually directly stimulate the beta-1 receptors on the heart. It acts as a partial agonist. But of course, an isolated heart preparation is not a whole body experiment. That's not a real situation clinically. What happens in the body when you put Pendolol in somebody's body who already has epinephrine or norepinephrine stimulating that heart? Well, epi and norepi are full agonists. So what happens when you have a full agonist and a partial agonist in the same situation? They compete for those receptors. In fact, the action of Pendolol is going to be to reduce the effect of the full agonist. Think about it this way. Every time Pendolol binds to a beta-1 receptor, epi and norepi can't bind to those same receptors. So the overall effect of your full agonist is going to be reduced. There's really kind of a similar story if you think about the drug tamoxifen. You've learned about tamoxifen perhaps as a SERM, as a selective estrogen receptor modulator, which is kind of a fancy way of saying that tamoxifen acts as a partial agonist. If you were to have a postmenopausal woman, no estrogen in her body, and you gave that woman tamoxifen, it would act as an agonist. It acts as a partial agonist. It would stimulate those estrogen receptors. What if you give tamoxifen to a woman who has estrogen receptor positive breast cancer? If estrogen is stimulating the growth of the breast cancer and you give that woman tamoxifen, that drug is going to compete for the binding to those estrogen receptors with the estrogen that was stimulating it. Ultimately, tamoxifen in the body, in the presence of estrogen, works as an antagonist. That's probably the most important take-home message. Partial agonists in the body actually work as antagonists. They inhibit the binding of the full agonist. When I look at the graph, typical dose-response curve, notice the partial agonist alone reaches some maximum response that's less than 100%. But the other part of this graph shows what happens if I start with a dose of a full agonist, which is going to be up around 100%, and then I start adding partial agonist into the system. The effect of that full agonist is going to be reduced. In fact, the more partial agonist I add, the greater the reduction in the response I'm going to see. If I keep adding more and more partial agonists, though, the response doesn't go to zero. The response, in fact, only reduces to what the maximum effect of a partial agonist all by itself would be. This is different from if this was truly a competitive antagonist. If this was a pure antagonist, I could block enough receptors to take the response of the full agonist all the way down to nothing. That doesn't happen with a partial agonist. It goes from about, in this case, 100% down to about 50%, which represents what the partial agonist all by itself would do. Kind of a final thought is, in that situation, adding the partial agonist in the presence of a full agonist, if I add enough partial agonist, that's all I'm going to see. I won't see the effect of the full agonist anymore. This graph allows us to talk about the concept of competitive and non-competitive antagonism, and also to look at the concept of potentiation. If you look right in the middle of this graph, you see what's labeled as control. Well, the control in this case is actually the agonist drug. And on the x-axis where it says log dose of the drug, we're actually plotting the log dose of the agonist. So when I look to the right and I see a competitive antagonist, keep in mind that most antagonists are in fact competitive. If we talk about drugs in our review and we say, well, that drug is an antagonist, your assumption is going to be that it's competitive because that's the more common action of a drug. Rarely we're going to see some drugs that are actually non-competitive. If I look at the curve, I notice how the competitive antagonist curve is shifted to the right compared to the control. What this is showing us really is it looks like the potency of the agonist has been decreased because the curve has been shifted to the right. When I give a fixed dose of a competitive antagonist, because of the competitive nature of that drug, I can increase the dose of an agonist and essentially outcompete the competitive antagonist. Did you catch what I just said? If you add more agonist, you can overcome the competitive antagonist. So why does the curve shift to the right? Because I'm using more agonist drug. And that means an increase in the amount, an increase in the dose. That is a shift to the right. Then look at the non-competitive antagonist. Examples of non-competitive antagonists, drugs like phenoxybenzamine or aspirin, allopurinol, and proton pump inhibitors, and probably others that you can think of. The non-competitive antagonist, notice down at the bottom of my slide, reminds us that many, many times a non-competitive antagonist is actually binding irreversibly to the receptor. Competitive antagonists, on the other hand, those are reversible binding. They're going to reversibly inhibit the receptor. And it's all about the type of bonding that takes place. A competitive antagonist binds to the receptor through weaker ionic bonds. Non-competitive drugs most often are going to bind by very strong covalent bonds, making them irreversible. Think about it that way, that if I've bound up the receptor with a non-competitive antagonist, I can no longer bind that receptor with an agonist. I have fewer receptors available to bind the agonist. So when I look at the shape of the graph, what a non-competitive drug does is it's going to decrease the maximum response of my agonist. Another way to say that, it decreases efficacy. So when you compare one more time, the competitive antagonist shifts the curve to the right, decreased potency. The non-competitive drug shifts the curve downward, decreasing efficacy. The shape really gives it away. We also have an example of potentiation. Potentiation is rare. There are not a lot of examples, and probably the best example is when you add a benzodiazepine in the presence of GABA. Well, if that's my example of potentiation, what's the control in that case? What's the agonist all by itself? Well, of course, that would be GABA. So imagine GABA is your control, and the example of potentiation is GABA plus a benzodiazepine. In this case, the curve shifts to the left. If you look at the word potentiation, it almost has the word potency built into it. In fact, I'm going to increase potency when I shift to the left. In other words, it doesn't take as much GABA to get the same effect in the presence of a benzodiazepine. That's probably as detailed as we need to get, but some of you already know about mechanisms of these drugs. If you know that benzos, for example, are going to increase the frequency of chloride channel opening, That only happens in the presence of GABA. So benzos are going to help GABA open that channel more often. If we want to summarize the different types of antagonism, we just covered one type, which is called pharmacologic antagonism. Pharmacologic antagonism divides into the two components that we just covered on the previous slide, competitive and non-competitive antagonists. It really implies that you've got an agonist and an antagonist, and they both target the same receptor. I've diagrammed that for you on my slide. So you have an agonist that can stimulate the receptor and an antagonist that can block that receptor, either competitively or non-competitively. The key, two drugs, both of which target one receptor. A second type of antagonism is physiologic antagonism. In this case, you're dealing many times with two different agonists that oppose each other. The text tells you about a vasoconstrictor combined with a vasodilator. How about a real example? Phenylephrine is a potent vasoconstrictor. It works through alpha-1 receptors, whereas nitroglycerin is an important vasodilator working through nitric oxide. Those two actions, even though they're mediated by different receptors and different pathways, those two actions oppose each other. So let's draw a diagram. So agonist 1 stimulates its own receptor. Agonist 2 stimulates its own receptor, and those two receptors oppose each other. And that's what we call physiologic antagonism. You can probably think about maybe the best example, which is the autonomic nervous system. Isn't it true that the sympathetic nervous system opposes the parasympathetic nervous system? Each of those systems uses its own neurotransmitter and different receptors to cause that effect, and they oppose each other. For example, on the heart, muscarinic M2 receptors stimulated by acetylcholine are going to slow the heart down, whereas beta-1 receptors stimulated by norepinephrine are going to increase the heart rate. Opposite effects, that's what we call physiologic antagonism. Our third example is called chemical antagonism. Chemical antagonism is where you have two drugs that actually bind to each other. There is no receptors involved in this interaction. So what you're seeing is a drug-to-drug complex, like you see with protamine binding to heparin. Two drugs acting to bind directly to each other independent of receptors. This is what our chelators do as well. Metal chelators bind up the metal independent of acting through a receptor. Let's summarize the three types of antagonism. The way that you can figure out pretty quickly what type of antagonism you're dealing with, you're always going to have two drugs. It's the number of receptors that's going to vary. So if I have two drugs and they bind to each other with no receptors involved, that's chemical antagonism. If I have two drugs, one stimulates the receptor and the other blocks that same receptor. Two drugs and one receptor, that's pharmacologic antagonism. But if I have two drugs and two different receptors, and the two receptors oppose each other, that's physiologic antagonism. Next we have what's called quantal, also called cumulative dose-response curves. I actually happen to not like either of those terms. I tend to refer to these graphs as population curves, and that's the key. These are graphs that are going to look at the percentage of the population that responds to your drug. It's this type of curve where you can estimate an ED50, the effective dose in 50% of the population, and also a toxic dose to 50% of the population. So when I look at the graph, once again I'm plotting dose, but this time versus the percent of patients responding. In this type of population graph, I can look at a therapeutic curve or a toxic curve. And it's from looking at those graphs, I can calculate a therapeutic index, which is formed by the toxic dose in 50% of the patients divided by the effective dose in 50% of the patients. Notice the alternate equation is LD50. LD stands for lethal dose 50. Those are obviously not experiments that we do very commonly. Have a hard time getting people to volunteer for those types of experiments. But TD50 over ED50, that's what you should concentrate on. So can you calculate the therapeutic index given this graph right here? Sure you can. If you look at the therapeutic curve, if you go to the 50% mark, go over to the curve for therapeutic and come down to the x-axis, you see it corresponds to 2 milligrams per kilogram. You do the same thing for the toxic curve, go up to 50%, go over and come down, you see that it corresponds to 10 milligrams per kilogram. So what's your therapeutic index? 10 divided by 2, which equals 5. The therapeutic index for this drug is 5. If you think about what that really means, it really means that if you take 5 times the recommended amount of the drug, on average you're going to get toxicity. You tell your patient to take one of these pills once a day and they say, nah, I'm going to take 5. Chances are good, given that this is the example we're talking about, that they're going to get toxicity. Again, some people do that, right? Don't people take more drug than we recommend? I call it the just-in-case rule. Not sure if you're familiar with this. I didn't know this, but for years I discovered that my father actually practiced the just-in-case rule. He once told me, I was taking some ibuprofen, and he once asked me why I was taking 2 ibuprofen. I said, because I have a headache. And he says, why just take 2? He says, take 4, just in case. And that actually explained a lot about what was going on and some of the troubles we were having with his medication. But if that's what your patient thinks, that more is better, what if it's this example? They say, well, I'm going to take 5 times what the doctor recommends. Well, you're going to get toxicity. So clearly, in order to be a safer drug, you want it to have a higher therapeutic index. The larger the number, the safer the drug is. That means the farther away your toxic dose is from your effective dose. If you look at a graph, that means the safer drugs are the ones where the curves are spread farther apart, and the more dangerous drugs are where the curves get close together. So what if I take toxic dose 50 divided by effective dose 50 and I get a number like 2 or less? Those are my really low therapeutic index drugs. Those are some of our most dangerous drugs. And here's a list of some of those that actually become very popular step 1 questions. Theophylline, digoxin, warfarin, lithium. All are drugs with a low therapeutic index. That means in a drug interaction question, if I have a P450 inhibitor in theophylline, remember the example from earlier? Theophyline's plasma levels are going to be higher. And that would be the case for a lot of drugs, but why is it that theophylline shows up in the test question or digoxin or warfarin show up in those test questions? That's because those are more dangerous drugs, and raising their plasma levels even slightly can lead to significant side effects, significant and possibly fatal side effects, making them better candidates for test questions.